Hello, welcome to the third episode of our Progressive MS webinar series. And today we're talking about the mental health of carers, and we're joined by Dr. Jonathan Egan, who is a clinical psychologist. Hello, Jonathan, how are you?
Robert, hello.
And I just want to give you a brief bio of Jonathan. So Dr. Egan is an academic and chartered health and clinical psychologist. He is also trained in both attachment and affect phobia therapies. His research has been in relation to trauma, its effect on person's psychological well-being. His other clinical and research interest is in how our own learned internal models of relationships, which we learn in childhood, can affect both professional caregivers and in people who are diagnosed with chronic health conditions, and whether they can learn to improve their ability to seek help effectively, without shame, in order to receive effective care and be met as a person who is an expert by experience in their own health status and needs. And Jonathan has a Twitter feed. It's at Dr. Jonathan, Jonathan, Egan, Egan, if you want to see what he's messaging on the Twitter world. So thank you very much for coming to this. And this is an area that's actually very dear to my heart.
Yeah.
And you know that in the discussions that we've had, Jonathan, over the last years, I have a big concern about the mental health of the people that are surrounding us, whether they are our parents, our siblings, friends, and our partners, the people who live with us, children. Our illnesses affect them in a way that is totally different to the way we experience our illness. And I often say this, that my illness is mine. I have no choice about it. And I cannot escape from it. It is always going to be there. But the carer is different. They actually have a choice, and they're there of their own volition. And I think that's a harder place to be. And I respect the time and effort that carers put into looking after us. So I think we have a responsibility to help with their mental health. So Jonathan, when I was reading your biography there, it's very much part and parcel of what you do.
Yeah, definitely. There's something profound. I suppose what we do is we become dualists. Our mind and body get separated. Ourself and other get separated when we think about ourselves, say maybe having a progressive MS and being in the context of a family or relationship. But the reality is that our lovers, our partners, our friends, our family members, they take us in because they love us. And in a way, they have a little Jonathan or a little Robert within themselves. A homunculus Robert, a homunculus Jonathan.
So what do you mean by homunculus? I've never heard that word before.
It's like a little mini. Imagine you internalize a little mini Robert or little mini Jonathan into your brain and into your soma, into your body. Okay. So when someone dies who we love, we have a grieving process, and literally we actually get into physical pain. With all the reminders trigger pain for us whenever we think of the person, or we would have been doing this with Robert today, or he loves the flowers or the cherry blossoms in April and May. So it's actually an illusion that we are the carer and caregiver. It's one system. So we have to view ourselves as a system. If somebody's sick in the family, the whole family has a sickness, and not the person with a sickness. So it's about how does that system work effectively is the key thing. There's a beautiful psychologist called, or a psychiatrist called Winnicott, and he said there's no such thing as a baby, there's a mother and baby. There's no such thing as a Jonathan, there's a Jonathan and his wife and family. So they will know implicitly when we're in pain, or when we're tired, or when the MS is flaring, or when our thoughts are becoming clouded, that our memory isn't working as well, that we're less fluent, that our sleep isn't so good. But it's about how we communicate in the system about that is the key thing. And in different current countries, you have different avoidance styles or anxious styles about relating. So it's very interesting if you're married to someone, say, from a different country, who has a different way of relating to pain. But in Ireland, we have a kind of a guilt-prone kind of culture You go ahead and you enjoy yourself there and just leave me all alone here at home. But you'd be fine. So it's almost like a martyrdom type thing can occur in some situations.
That concept I find very difficult, because it's setting up the dynamic between the cared and the carer for a fall at some stage. Because if the carer is always feeling that they need to give to the cared and give them the time, give them the space, go off and do your thing, they're no longer looking after themselves. And their whole identity then becomes wrapped up in the person that they're caring for. And actually, I want to note for people who are listening to this, if you have any questions, please ask in the Q&A and I'll pass them on to Jonathan, because everybody's experience of being a carer is different. And I've had my experiences. So anyway, Jonathan, just to go back to that point of how do you get over that hurdle of martyrdom?
So if we bring it back to kind of a hardwired biological response, if there's somebody we care about is in pain or is seeking help, it triggers a caregiving system within our brain, which is hardwired and it's biological. And we can't think of anybody else or do anything effectively in work unless we actually seek and assuage that person's fear or distress. Okay. It's hardwired. And also within that system, there's the other half of the system is the care seeking system. And this is where we aren't very good in Ireland with. It's how do we trigger the response from the caregiver that I need help. Can you give me help? I'm distressed either, or I need some instrumental help from you. So that's the way the system works, and it's hardwired. And if you doesn't get response, and it's what we call goal corrected. If I'm hungry, I need to eat for my hunger to go away. For me, if I'm distressed and I need help, that system will not turn off until I receive help. And the only way to turn
Are you saying that the carer, they need something from us in response to their need?
So it's not it's a goal corrected system. So once it's turned on, once someone presses the key, I need help, that'll be trigger if someone cares about you to try and help you in any way they can. And that system won't, for them, get turned off until they feel, and you'll know it when you help somebody and then the person goes, oh, thank you, and there's a relief. The caregiver gets relief. The problem is, and I think you've identified here, is when there's a chronic condition and there isn't clear communication between the caregiver and care seeker and caregiver, that both end up feeling frustrated and distorted. One ends up feeling like a burden, and the other person feels like that, I don't have my own life. So
and that's the problem. That's exactly it. And I know myself, one of the issues that I'm continually battling against, I know with my partner, is I always want my partner to be my lover. I don't want my partner to be my nurse. And to make sure that doesn't happen in that relationship. It's very easy. It's so easy to fall into that needy position, and you're setting up this wrong dynamic.
And we humans, we're pain avoiders, we're anxiety avoiders, and there's always what we call secondary gain. When I was a child, I had asthma, very brittle asthma, and obviously I'd seek help from my mother or father to take the inhaler when I was getting an attack, and I go to hospital if I was getting into a brittle kind of status asthmaticus where I go blue. However, I used to be able to get off double accountancy if I breathed in a funny way. So every illness, no matter what it is, has a secondary gain. In that if we're not very careful, we as care seekers can easily use it unconsciously to ourselves to get out of situations and things which give us bother or are difficult. So that's the personal responsibility side. But we're not very good in Ireland at asking for help. And then we're not very good at, for example, when people come to me with a chronic pain or MS, what I've noticed, which is effective, being an effective caregiver, is I notice, Mary, that around half an hour into our session, I don't know if you notice it, but I'm not sure if I've been of value. I'm not sure if I've been a good professional caregiver to you from that moment on. And in fact, instead of charging €150 for the hour, why don't we work about 20 minutes or half an hour and see what works there? and reduce it down parametrically. And they go, oh my God. And it's a sudden meeting of okay. Because, and I reckon there's a lot of people with MS and different progressive MS attending counsellors for like an hour when the last, I don't know, it'd be lovely to hear the people in the audience and that their perception of that it's not effective care seeking or caregiving.
And I've experienced that. And I have to say, when I'm with you in a session, Jonathan, you pick up those triggers very well. Yeah. And you've cut short sessions because you said, Robert, I'm just not able to give you any value. And I'm trying to translate that back into in real life home situation. Now, there's two different types of people, right? They're the people who are very empathetic and can understand your feelings, and they endeavor to understand them. And then you have those who want to fix you. Okay. And with like multiple sclerosis or other illnesses that somebody could have, that if you want to fix that person and you can't, that impotence, that inability to solve the problem. I know for me that's a huge struggle, because my first instinct is, okay, what do we need to do?
Yeah, exactly.
And if you can't, how do you become that empathetic person when you're one of these fixers?
Yeah, and it's hugely shaming for the person. And it often brings it back to how we learn to interact and seek help and give help. It often comes from our relationships with our parents or teachers or someone in childhood. So for somebody who's got a partner with a chronic condition, and when they go into problem-solving mode, and then, in other words, their care-giving system gets activated, but what they do isn't effective, and they don't get the relief in their partner or the person they care for, they will, if they've had a difficult childhood with a parent maybe who depression or had another chronic illness, they'll go into self-shaming role that I'm not a good person, I can't take care of another person. And that can be very difficult, and it can result in people avoiding each other. And I find people, couples, when they come into me, they'll avoid the gaze in each other's eyes. They'll avoid that very close emotional contact. The real momentary awareness that, oh, we're really close together at this moment. And that what happens is people start to drift apart and go into instrumental relationships of quid pro quo, of I'll do this and you do that, and that's our roles. And it's like two people living on a desert island together, but not really in a system anymore. It's two different systems working, and both ineffectively, and both feeling worse and worse as it goes on.
So if you find yourself getting into that position, are there things that the carer can do to pull yourself out of that situation?
So the first thing we need to do is, imagine you're driving a car and you need to discriminate, use electric car, you need to discriminate petrol stations which have electric points, or if you have a diesel car that has diesel or petrol. So we need to identify people within our system who can actually give care. We need to sit down with a piece of paper and go, okay, who meets me? Who gets me as a person? Who understands me? Who just implicitly doesn't try and reflexively go into action when there's nothing that can be done with this? It's just, I want you to meet me where I am now, right now, feeling powerless. I've got a flare. I'm really worried about the future. Currently, I'm not coping as well, I'm not sleeping as well. And to be able to sit with that and go, okay, wow, that's a really horrible place to be. I feel powerless like you. There's nothing can be done here. But being met in that moment is all people need. We don't need to, and that's where clinicians and friends and lovers can get really frustrated, is that they'll try and move into that. So what we need to let them know is, what I really need now is an ear, a listening ear. I just want you to meet me where I'm at. That's all I need.
Is that the responsibility of the cared to say that this is all I need at the moment?
I think it's the responsibility of us with a chronic condition.
Okay.
I think we have to bring back the responsibility about how can we become a discerning care seeker.
But I'm trying to see it from the perspective of the carer themselves. And
the carer, okay.
Yeah. So I remember when I was helping to look after my mother. She had terminal breast cancer, and that inability to actually solve her problem, but then there was the day-to-day mechanics of, keeping her going, getting her up in the morning, breakfast, all those daily routines.
Yeah.
And sometimes I know she was angry, and that was the illness that was there, and she was angry at the illness, but it was directed at me, the caregiver. And she was my mother, and she was angry at me. So how do I not start reflecting that anger back on her again? And also it draws you down because you've lost the person that you love.
Yeah, exactly. So that's what we're talking about. It's called projective identification. It's where a person is futile and angry but can't express their futility and anger in an effective way. So they unconsciously get the other person to get angry and futile in a futile place with them, and it creates a war, battle. And that means there's release for one person, the care seeker, but the caregiver is left completely bruised, feeling used, and this is not fair, and hurt. So there's the bit about saying, okay, how can we more effectively talk to each other about what you need? And it's about, because no one wants to be, most people don't want to be sympathy or being, that sympathy care. No one really wants that, unless, if they're mature individuals, they don't want that. So it's about saying, okay, let's have a conversation about what do you need and how can we more effectively get you to trigger me to take care of you. Sometimes I need to just pause and say, is this what you need as a caregiver?
And when do you have that conversation? Is it at the time of the explosive event?
I don't think it's not the best time. It's about sitting down at a time where it's both good for you. For example, some people are morning people, some people are evening people. It's about saying, let's sit down. This isn't working. Not the relationship, but the way we're related to each other is not working. We're both hurting each other. Can we sit down and talk at a time that we're both in a better space, and see how we can, because people often will use if they haven't had an effective care-seeking style from childhood, they will use eye glances and furtive looks and sighs and bodily winces, which aren't effective ways of asking for help. And then what'll happen is they'll get annoyed that Robert didn't pick that up. He didn't see what my need was there. But I was care-seeking, but not in a very effective, expressive, outward way. It was in a furtive. It was in a harsh way that ends up shaming the carer, and really it leaves the carer feeling pretty rotten about themselves. And then also what will happen is, if you're human, I think, is you start to avoid the person in different ways and thinking, oh, I'm getting respite or relief from them, when it's more about getting respite and relief by doing effective caregiving, care seeking, and also by both being able to say, this is a bloody mess, isn't it? We can do nothing about this. It's just, and both being able to sit with the sadness or to sit with the frustration or to sit with whatever is happening there. So it's about having a moment-to-moment conversation as well as a planned conversation.
Is it the type of thing that should be scheduled into your daily routine?
Brilliant. Yeah, that is super. Yeah, brilliant. So what I think people need to do for themselves as care seekers or caregivers is to make a note, have a little diary or something, make a note and go, okay, these are the things I'm thinking about. And whether it's for care seeking or caregiving or just basic needs, which you've identified, and how is the best I can. And maybe your partner isn't the person who can give that. So if you have a very practical problem-solving partner, they aren't the person who's going to meet you as a person without clicking into the doing. So then it's better to identify a friend outside that circle or a relative or a professional therapist, and for them not to be doers as well, or your doctors or your GPs or your specialists, but also to recognize that sometimes your specialist is not the right specialist for you, that caregiver, the professional caregiver. And what we do as patients is we try and teach them how to meet us in our ways. But sometimes it's the wrong person. They might be very good technically, but unless you have somebody who meets you as a person, but also has that instrumental caregiving thing, unless it's an operation where you don't really care about the relationship in that way, that it's something that you fix. But it's an ongoing long-term thing. You need to move consultant. You need to get to somebody else because what will happen is you'll leave those situations with the specialist nurse or the specialist physiotherapist or the specialist consultant feeling frustrated and not listened to, and obfuscated and disregarded, and not it's almost like the person hasn't taken you in, hasn't tasted you, hasn't brought you in as a little homunculus, a little Robert, a little Jonathan in there. And as soon as you've gone, left the room, they don't have an image of you anymore in their head. And you feel that.
So again, coming back to the way this feels for the carer, that I think it's really difficult to change that role. So you when you started off, say for example, a relationship, and you were these two different types of people, and you love each other, and it's a good, strong relationship, and then this illness comes along, and it changes the dynamic. It changes the balance within the relationship.
Okay, I remember the triangle we talked about, I think, in a previous webinar.
Yeah.
So the one thing that gets in the way of effective communication is guilt. When guilt is there, we don't effectively communicate. We communicate from a dominant or a submissive place in a relationship. So so the question we need to ask is the way I'm caring as a caregiver, is it effective? When I do it, do I get a sense of relief in myself that it's completed? Yeah, I've actually been effective there. And does the person who's seeking care get a response of relief, or their need is being met? And to be really open to myself and go, okay, if that's not happening, there's something wrong happening in the situation. Either that I'm not being triggered in the right way, I'm not identifying what the person's needs are, or maybe they aren't looking for help at all. A lot of people will go into giving help and it hasn't been requested. It hasn't been, and that's unctuous, isn't it? It's horrible when someone does that. And when people, there's amazing studies where babies, the anxious mother or father, will keep looking at the baby. When the baby eventually needs a bit of space on their own, they turn away, and the anxious mother or father will prod the little baby in the face to bring it back. But the baby needs the time to have space. So part of the care-seeking caregiving is it also needs an essential pause in between. Get out of my face. You're being intrusive.
And
after that.
And should that be programmed again? Like
I think so. Yeah.
And see, this is one of the taking MS as an example. So you've programmed. You've decided that next Friday your carer is going off for a day shopping or going off to friends, having a cup of tea, whatever. When this COVID lockdown all finishes, but and then on that morning, I'm bad. Right. I can't get out of the bed, or my pain is a lot worse, or whatever those symptoms are, and I need that person on that day. And they've already scheduled their time off, which is needed, and that system collapses then. Okay.
Well, the system doesn't collapse. It collapses in that if we aren't effective in stating and inserting our needs, then it collapses. So it's a situation, because if you think of it as two individual separate people, yes, that those two separate systems which aren't properly connected collapse. But in the reality is, if your child gets sick, one person will have to take a turn going off work or whatever. That someone within the network needs help. So what happens to happen in that system is that the person has to then take care, and the deal needs to be, when I need care, and that you need to hold on, because you're not in need then. The other person's not in need then.
But does it not build up resentment?
Well, it could so what I'm trying to say, once we clear the woods from the trees, then it becomes a lot easier. You're identifying the right petrol station to pull over to get what you need. But if you aren't very clear in that and agreements, and that sometimes, yes, things will go completely wrong and you'll be missed, your care needs will be missed, then that's when resentment will be met. Because when our attachment system, when a care seeks, when it goes, I need help, I can't even get out of the bed now, I can't do anything here. And if the person doesn't respond to that help, a huge what's called attachment protest occurs. We get really angry. Like in a really irrational way, like a fuming way. That person is evil. They just don't get it. And everyone does that. And so it's a normal part of the attachment behavior, attachment fury, if our needs aren't met. And what happens is that fury is meant to go, well, hang on a second, I wasn't messing, I wasn't putting it on today. I really need your help. And for the person to realize, if someone's getting really furious at you, it means that you're really missing the the cues the person's giving. Now, are the cues identifiable? Maybe they aren't. For me, as a psychologist and kind of an attachment therapist, I will look at micro stuff, but I'll clarify and go, I've seen a little kind of look in your face. What's that about? Or is it just data? Just throw it away. To explore it and to try and get the person to move from the facial seeking, the winces of looking for help, to actually put it into words.
So then should the carer then start saying to, say, my partner could say to me, Robert, I noticed you're making this gesture.
Oh yeah, yeah.
Does that mean that you want something? Right? Yeah. Do we have to learn how to vocalize or learn to say, I'm trying to learn your tics, your habits, your things.
Yeah. So and it's almost like saying, we do with children. We're not going to try and patronize people, but we say, put that into words, Ted, my son. Let's try and put it in words together so I understand where. So it's about, do I understand you now? Am I getting you? Am I meeting you as a person? Mm-hmm. And because if it doesn't happen, then the frustration gets into the system. I think so we're identifying this is frustration. And when frustration occurs, we then distort the other. And then when you've distorted the other, you go, hang on, that's not me. That's not bloody fair.
Yeah.
Okay. I'm not patient. I'm your partner. I'm your lover. Don't you dare treat me that way, as if I'm someone in a wheelchair or whatever. Because that means you're distorting the person and not giving them their own autonomy and their own capacity as a person.
Okay. And now we have one question here in the chat. If I can read it out here. My wife is a very loyal person, but does not want to get involved in my care. Okay. She works full time and we have 2 young children. I have a home help 2 hours per day. Okay. I have MS and scoliosis. Okay. My wife seems unable to address the practical stuff and leave the care to the professionals who are only available on a part-time basis. We're married for 15 years. How do I unlock the conversation with my wife?
Well, that's a huge, and that's why it's so simple, the answer to this, but it's also terribly frightening for people. Right. Because particularly, first of all, I want the person to ask themselves, what was it like for them as a child asking for help? If they cut their knee or were bullied in the schoolyard, who did they go into their family to seek help? And if they don't answer the mother, that's unusual then. So something's different in the system, something wrong probably. And they go to the dad for the help. Okay, so the system wasn't working, the help-seeking and help-giving, caregiving system wasn't working. So it means that you have to be very gentle with yourself, that you probably have a messed up system there. That's not, the code isn't right in it, the algorithm isn't right for seeking help. So that's the first place to look, because the pattern is probably being repeated now. So when a person's around a lot, we will call them a loyal person. Okay, mm-hmm. Like in a royal court, you're a loyal subjugate. However, the reality is your MS doesn't turn off during the day. There are probably times, if you diary, which I think is hugely important, to identify the key times when help is needed, instrumental help, as well as key times when emotional help is needed. And to say to your partner, I've identified sometimes when I actually will need your help. I just would like to plan this together, in that I know you don't like doing this, but I'll teach you how to help me in this way. So that it becomes a space, or for that person then to say, well, I can't do that. I have these needs. We need to then identify somewhere in an external system or within the family system where I can get that help. It's difficult, but it's scary.
That's really scary, because you may not have you may not have that other network there to transfer to. So,
and that's why I just ask you to really be gentle with yourself and ask about your own childhood and how it was to ask for help as a child, because there could be an implicit thought that the person doesn't really love me and care about me that much if they can't do that. And if I open Pandora's box, do you know what I mean? So that's why it's so frightening. Be really gentle with yourself that way. But I think if a person is loyal, has been there, what often happens is it's usually the male that goes away and the female, and what happens is the person goes into spending busier time outside the home because they feel incompetent as a carer. When you feel incompetent as a carer, it's better to go off and do work and be busy and become a workaholic, or play bridge or play golf and do your busy man or woman things outside the house, because it's horrible to feel incompetent. I remember when my first baby was born, as a man, I wasn't prepared for this at all. I never had younger siblings. And I was just felt completely incompetent about changing nappies, doing everything, and just the pure tiredness and that. Until I asked help about how to learn how to give the help. And when that happens, then you start to go, okay, I can do a bit of this. So there's something about the person might feel incompetent. They mightn't feel that they're meeting your needs, and that the system isn't. When we help somebody, they should get a real sense of, I've helped. If you're not getting that, then the system's broken.
So then you need to have that frank conversation.
A frank and caring conversation where this is the hard bit for the care seeker is to say, I have these needs. Can we discuss how you can help me meet these needs? What you can and can't do. So we have a problem if you can't.
I'm going to ask Aoife to put up we have a very brief poll to put up just to find out the age categories of stuff. If you could put that up while we're talking about this.
Yeah.
I can actually understand where this guy is coming from, because there are those practical things that you need to have done. And for example, I know myself, if I was I wanted to cook the dinner tonight, for example, and this was the day that I was going to do it, and it was going to be good for our relationship that we're sharing the task. Now, cooking dinner for me takes a huge amount of effort. Okay, it's a big deal for me. And then you start to do it and you can't. Okay, and I'm going to have to ask my partner, this is the time when I need your help. I still want to make the dinner, but can we do it together?
Yeah.
Okay. So this is now drawing on that person.
Yeah.
Right. And they thought they were going to have the day off. They were going to have the day off cooking, and it was going to be a special thing.
Yeah.
It's that.
Yeah. Yeah.
Sorry, that's a bit of a clash.
It's a clash. And I think it's a bit like with COVID now, that people in Ireland like to work hard and then be bold at the weekend. Okay. So that kind of idea. That's not reality based. Okay. So there's something about saying, okay, these needs are still going to be there no matter what.
Mm-hmm.
However, is there a way we can be clever about that, looking across a week such that that you will cut the vegetables not there, so I will be able to prepare it, so it's done beforehand. Mm-hmm. So it's about saying, okay, the care could be preempted sometimes, rather than having to be met in the situation. But it's a bit like when I used to work in a child guidance clinic 20 years ago. And I talk about it to parents, and they go, but it's horrible on the kids and getting met in the morning. I said, well, if you got up an hour earlier before the kids and did all this, or did the night before, what would happen? And you'd always know about 70% would tell you to F off. But there would be about a third who'd go, geez, I never thought of that. It's kind of the explorative caregiving where you're thinking about things and go, will that work? And the ones who do it then, who have preemptive care strategies, care packages, that works brilliantly, that they can actually start to plan their environment externally, that that it can occur in that way. So it's about those kind of things that so it might mean your partner cutting all the vegetables and having it prepared for you and boxed in the fridge. So all you need to do then is do the creative bit.
Okay, so and again, this is all down to planning and pacing and regulating what you do.
People hate that. We want to intuitively love each other and know what each other's needs are. But I don't know, I'm a psychologist and I haven't found that to be effective. We have to articulate it out loud.
And I know myself, I find when I go on my walk with my partner, that's the time when I discuss all of this stuff.
Brilliant. Because we love going in a direction with people in a thing. Yeah.
You're going in a straight line, you're having a conversation and you're sharing the stuff, and it's out of that environment of the home where that stuff is happening. Now, there's one or two more questions here. My husband has MS, and I feel I give a lot of care to make life easier for him. At times, for no apparent reason, he gets very frustrated and verbally abuses me, which makes me want to leave.
Well, I want to leave as well. So it's I'm thinking maybe that her husband might have depression in the background there to really explore that. He might have cyclothymia, which goes with the fatigue of the MS that he's experiencing that. And there's no one's right to we can be angry, of course, and snappy with each other, as every couple is. But that discussion is as when I caregive, I don't want to be abused. Like in any library or guard station or any clinic you go to, they have things, do not verbally abuse the staff. However, there could be that other conversation, but I wouldn't have, if there's any one-sided facial bits of contempt, that means you're never going to be able to win that conversation. That person might have contempt and hatred for you. And that's a different situation. Have a look for the one side, the snarl. And so they're going to meet that person's needs.
And if you see that, can you overcome that by waiting until a neutral time when you're both a bit more calm? Can you help overcome that, or is that
in some situations you can, and what can happen is you're a lookalike for the mom or dad from the past it's been reactivated, who didn't care, who didn't give a damn when they had the asthma attack, or they had the cystic fibrosis, whatever it was, or musculoskeletal pain, who didn't attend when you were trying to seek help, and what happens is then you'll get a reaction of contempt to the person, the attachment protest. So in those situations, if the person's a lookalike, you need to ask yourself, am I a lookalike for his mother here?
Okay.
In that situation, say, look, you're treating me the way you treated your mother treated you. Do you notice that? I find that very upsetting. That really hurts me when you shout at me and make those faces and that. We need to find a better way, otherwise I'm gone. I can't stay here.
So, and that's the honesty in the conversation. I think that you both want to find the solution to it, if there is a solution, right? And there are times when you have to admit that it's not going to work, or you're going to have to bring in third parties to figure it out. So Aoife, if you could close that poll thank you very much, and we'll put up the results of it. So this is the results of the poll. Primary progressive, 27% have that, 13% secondary progressive, 20% relapsing remitting, 20% are carers, and 13% are friends and family. So I'm delighted to see people who are coming to this, who are, and particularly friends. And that's another dynamic that we should look at. We have people are mainly living in actually Munster, 53%, and the predominant ages are over 46.
And that's lovely. We say friends, we need to start thinking about, okay, who can give us our vitality? And people who give us vitality are people who have shared interests that we have. Okay, and that mightn't be your spouse. It could be a friend or somebody outside. But that person who gives you that vitality lift and the shared interest might not be a good caregiver.
Okay.
So what we tend to do is go bashing our heads against and asking for help from the person who can't give us help. And it's unfair because to the caregiver, because they haven't got that. They've got the golf or the bridge or the watching movies shared interest, but they aren't a caregiver.
And if you are that friend, okay, and you just don't want to do that role, you're not cut out for it. Do you then have that conversation as well with the friend that you have that has this disability? Do you say, look, I love you to bits. We're great friends. We have a fantastic relationship, but I just can't do that bit for you.
Exactly. And that opens the air up. And, if you're coming from a mature place, you go, that's actually the truth. We're ruining the relationship by me looking for care and needs in that. Now, most friends will do certain amounts, if you need help moving and whatever else, that's going to be normal. But it's about the other things. If you suddenly start to project onto a friend kind of things that your partner should be doing or someone else should be doing, that's different. I think it's about clarifying, okay, what's the role here? And people we get energy from often aren't caregivers. They're the people we've shared interests. So it's a different category of what we need.
And I think it's actually when you find that vitality outside of your relationship.
Yes.
And you bring that excitement back into it.
Brilliant. It's brilliant. And then we feel sexier.
We're
filled with vitality.
You've got life back again.
We've got the light is back on our eyes.
Mm-hmm. Now, before we started this, there was a couple of people had sent me some questions as well. How do you correct an unwanted behavior by a carer without alienating them? And I know that we're going to be talking about this more in another webinar that we're going to be doing.
10 sessions in this,
and is it okay to suggest to that carer to see somebody, a mental health professional?
Definitely. Well, I suppose because in a way we need to send a subtle message saying that, I find that a bit intrusive. That isn't helpful to me. What I would need is this, but I'll ask you for it if I need it. But I find it a bit, I don't like the way I'm treated in this way. And to be very open with it and to say it. And when we say, do you ever notice people you have to practice this, because people who are good and say, well, actually, I'm very unhappy with the contingency plan that was written up there. I've thought about it, and these are the two things I think we could consider. Nobody gets offended by that. So a person's asserting what their need is. I think it's when we're not used to it. It's a bit like having a machine gun. Initially, when we start to fire, we shoot 100 holes until we learn to direct exactly where we need to shoot to meet the goal. What I'm saying is this. I'm feeling anxious because it's really difficult stuff. What we're talking about. It's really simple, the answer to it, but because of the way we've been brought up and the way we've been the social morals and norms aren't effective in the way we've been taught. So we have to, first of all, go into ourselves, into our body and go, what do I need? And then to move from the need to identify a person who can meet that need. And if that person's not there, to move to another person who can meet that need.
Yeah. Okay. I'm thinking about some practical things to help the carer as well. And we're only have 4 minutes left, Jonathan. So I don't want to put you under too much pressure, but I know practical things that can help balance the mind of the carer. And I know as somebody with a disability, I do my mindfulness practice every day. I do my journaling every day. And I spend that quiet time to inner reflect every day. Yeah. Is that something that will also help the carer in managing how they react to things?
Yeah, I think being a 24/7 carer is difficult. We know that. I used to work in cardiac rehab before I moved into kind of pain and chronic conditions. And when we measured the couples over time, when a partner's mood goes down who has care need, so would the spouse. So they need to sort out their own well-being kind of practice, as you're saying. Some of it, which isn't interpersonal, it's to do about stress levels and that, and it's either by having walks at certain times or by doing mindfulness or some kind of meditation process. But if it's created relationally, sometimes it needs to be cleaned up. The dishes need to be cleaned as we go relationally. So it means going for a walk, as you say, with a friend who you can talk about, oh, geez, I found it really difficult with Jonathan today, love him to bits, but he's been a real ass. And to in that way. So there's relief, but it's relational relief. So in other words, it's almost like we're little sea creatures cleaning each other off. And that needs to happen in different situations, as well as saying in that conversation, that hasn't been very effective. Let's not keep repeating the same pattern and come back to it. But I think it's hugely important. And we know that depression is very high in caregivers. And depression occurs when we feel helpless, hopeless, and when a system we keep repeating doesn't work.
Are there any particular resources available that people can go to, say, on the internet, or if they don't have the resources to pay for a psychologist or psychiatrist, or should they speak to their GP about this?
Lots, as you know, there's MS Ireland, and there's lots of different help groups that are there for depression, or there's plenty of I've gone blank, but plenty of different mindfulness apps which are easily available online. And try those, but don't do. I've had people come to me. I've been doing mindfulness for 2 years and it doesn't work. Go, why are you doing mindfulness for 2 years when it doesn't work? Because I was told it will help, but it doesn't help. So and then
okay, so there's up in the chat here, insight and cognition can also play a big factor for some. The sanctuary.ie offer free mindfulness sessions every week. That's a nice tip. Now, as we're coming to a close on this, thank you very much, John.
The blackboard. Everyone needs a blackboard in the house. Or a whiteboard where everything's written up. It's in a contract on the wall. Sorry.
That's a good idea. So we're coming up to the close of this, Jonathan. So thank you very much for your time. We only scratched the surface, I think, of this, and perhaps we can come back to it in another stage. The next webinar is going to be on May the 27th, and I'll be speaking to Lorna Spellman, who's an occupational therapist. And I know myself, I have the stair lift and I have the mobility scooter and I have all the other aids and appliances, and they make a huge difference to my life. And the occupational therapist is the one that gives us those tools to allow us to continue to be more effective in our daily routine. So I'm really looking forward to that conversation. My name is Robert Joyce. I've been your host today, and I've got a blog, A 30-Minute Life, where I share my experience, and you can catch me on Twitter and on Facebook too at A 30-Minute Life. Jonathan, thank you very much. Oh, and I want to thank the MS Society. They have been fantastic in giving us the opportunity to do this. And in particular, I'd like to thank Aoife Kerwin and Aidan Larkin, who have put this together and allow it to happen. Yeah. Thank you very much. And we will see you all in a month's time. Goodbye.